So, rural medicine been quite hotly debated in the media recently as fallen apart and really be a difficult place to actually practice, chronically short of practitioners and supports. How are things? You clearly have been there for a while. You seem to be loving it. Obviously, now with your role within the AMA, advocating on behalf of the rural family medicine physicians out there. Like, what's the state of the union currently like?
Well, we have been at the crux of what we call geographic narcissism for decades. So what that means for everybody that doesn't understand is I would hear everything outside for Alberta would be outside of Edmonton and Calgary. There is very little, if any, understanding that there's actually physicians and medicine and real things happening out in rural Alberta. And we've been having that happen for decades. So for decades, we've kind of kept the patchwork together, kept our hospitals open, seen all our patients, made sure that we still have these economic pipelines of money flowing because we've still managed to stay out in rural Alberta. So the state of the union for rural is probably the same as it's been for many, many decades. And what hasn't changed is that we're also the kingmakers when it comes to any government. So government doesn't stay in power unless they have us. So now it's time, again, like all my predecessors, to say that rural medicine, rural generalists, we need to be at the focus. We need to be first, right? We've been providing gold standard medical care and team-based care and all the wonderful words and acronyms and concepts that are now suddenly the city is thinking, wow, that would be nice. We should do that. And then we should do it and tell rural. Well, surprise, we've been doing it for a long time. So how about we just tell you how to do things for once and we'll go from there.
So do you think it's sort of similar right now in the city how it was in the rural areas for a decade ago, just in terms of the availability of physicians and locum coverage and all those things that we are currently describing as falling apart and the system crumbling?
Well, there's a nuance there. So definitely when it comes to the acute care facilities in the city, they have all those problems. But that is a like most things, Jordan, there's so many variables into there. I mean, one of the big variables is the fact that the acute care facilities and the teaching hospitals have all been relying on the residents for a very long time. So now, suddenly, when residents are actually getting more focus in having more of a balance, not being just treated mishapenly in the hospitals and not having shift after shift after shift, suddenly the services are going, oh, you mean I don't have a whole bunch of residents that's going to help me do the job that I'm being paid 6 or 7 figures for? Well, now we're going to have to reduce service as a result of that. Now, when the public hears that, they're like, what? Right? So, like, no, I'm pretty sure we have physicians and you have trainees. The public doesn't understand that the trainees are such an integral part of how the hospital stays open, how beds stay open, how wards continue to stay open and services happen. The public has no idea about that. But that is a very big component as to why some of those teaching hospitals, why some of those services are reducing. Another big reason is that there's just a general change in work ethic, right? We have physicians that are coming out in the first 5 years of practice, and rather than the senior physicians in any of those departments going, well, you know what, I'm going to slow down as far as my night call goes. Now we have physicians in the first 5 years of practice that go, I'm not doing nights at all, and if you don't like it, I'm quitting. Right? So like this is the state. So it's not all that we got here because the government did a whole bunch of bad things to us. We got here, a lot of it, because we got ourselves here, and nobody was really putting all the pieces together to realize that variable X, Y, and Z, and if all those things happen, and we have this Swiss cheese model of everything falling down at the same time, that this is where we're going to be, but this is where we're at.
And then just given that the residents are basically supporting and running a lot of the functions that are out there, how did things go in terms of the CARMS match this year for the rural areas and the rural programs in the province?
So the CARMS match did go better than last year, but as everybody who's listening, or as you know, we really had nowhere else to go but better, right? So last year was pretty horrific, especially when it came to
It was a little
family
rough.
medicine and rural programs. Like it was very bad. They filled it in, kind of in the in the after the fact kind of what we call third match of how they just kind of filled the program. So they all did fill, right? So as far as the public can understand, there is going to be this decline of physician output. It's still going to remain stable even from last year, but this year they did quite well. There was still some empty spots as far as the very rural goes after the first match.
This episode is sponsored by Empathia.ai. This AI charting assistant captures your patient encounter and creates a clinical note, saving doctors on average 2 hours per day in charting. Healthcare professionals are often bogged down by endless paperwork. Their goal is for physicians to spend less time charting. Find them at www.empathia.ai. That's EMPATHIA.ai. I'm Dr. Jordan Valrath, and you've been watching Cherry Live, brought to you by Cherry Health. Please like and subscribe to see more clips like this, or check us out at www.cherry.health, Canada's medical network.